Thank you, and good afternoon, everyone. It's an honor to be here again in Krakow, my second time, and thank you so much for the invitation to come to this beautiful city. So I will start off talking about amyloidosis and spend a little bit of time on the management of POEMs. So again, when you talk about amyloidosis, it's again a broad spectrum of disorders. The only thing that is common across all amyloidosis is the fact that they all have the amyloid fibrils that can be derived from a variety of different proteins. And as the diagnostic techniques have improved, we now understand that there are over 40 different proteins that have been identified to be capable of producing amyloid fibrils. And they all carry the common characteristics that when you do a Congo red stain, they all have this appearance that you see up here, and then you do again, this birefringent, apple green birefringence that you can see under polarized microscopy. And they all have this beta-pleated structure when you look at it under the microscope. Now, broadly, you can think about the amyloidosis that we see in the clinic as the hereditary ones, which are obviously less common, and then also the ones we see as hematologists much more commonly is the light chain amyloidosis. So among the hereditary types of amyloidosis, again, the familial type, the transthyretin is the protein that is abnormal here. Normal transthyretin can lead to senile amyloidosis. Now, this is again a very short list of different proteins that can give rise to amyloid fibrils. We know that list is much longer. Now, when you talk about the acquired type of amyloidosis, which is again, as I said, what we deal with more commonly, and amongst them, the most common is the light chain amyloid, which is what I would focus today's talk on. Now, in areas where there is chronic infections and chronic inflammatory conditions are much more common and less well controlled, patients can get secondary amyloidosis from the serum A protein. So the first step is, how do we make the diagnosis of amyloidosis? Now, the problem with making the diagnosis is the symptoms can be very slow in onset, and the vast majority of the patients will not have a pre-existing monoclonal gammopathy. When we look at our Mayo Clinic series, only 6% of patients whom we diagnosed as amyloid had a pre-existing monoclonal gammopathy that was known to exist prior to the diagnosis of amyloid. Obviously, all these patients had the monoclonal gammopathy for some time, but it was never diagnosed prior to the amyloid diagnosis. Now, when you think about the symptoms that the patients with light chain amyloidosis present with, symptoms like fatigue, weight loss, edema, paresthesia, none of these symptoms are characteristic of one disease. They are very common symptoms, and amyloidosis is not the first thing you think about when a patient comes to you with these symptoms. However, when somebody comes in with some findings like this, which are very characteristic, I think there's no mistake. The diagnosis is pretty clear. However, a very small fraction of patients will come to the clinic with these kind of features. So when you suspect amyloidosis, I think there are three things we need to do. One is, obviously, we need to show that there's amyloid somewhere. We need to show that the amyloid is coming from a specific, whichever type of protein they are coming from. And obviously, when you're thinking about light chain amyloidosis, you'll be starting off with screening for a monoclonal process. So when you see somebody in the clinic and for whatever reason they have had or clinically you're suspecting someone has amyloidosis, you do biopsy, you show that there's amyloid. The first step, obviously, as we talked about, the most common is light chain amyloidosis. So you screen for a monoclonal protein. And again, as with all monoclonal gammopathies, you want to do a serum electrophoresis with immunofixation, a urine study. But if you do both these, you still have only about 95% of these patients would have an abnormal finding. You're still missing 5% of these patients. If you add to that free light chain ratio, that by itself picks up 91%, but if you do all three, almost all patients with light chain amyloid, you will be able to detect a monoclonal protein or a monoclonal process. So the one thing I want to highlight is, we talked about, if you just want to find out if a patient has a monoclonal protein, you actually can do a serum electrophoresis with immunofixation and a serum free light chain, and you'll pick up the vast majority of the patients. However, if you're thinking clinically that the patient has amyloidosis, a 24-hour urine is an absolute must, because many of these patients can have small light chain, levels of light chain, which can sometimes be picked up in the urine, and also at the same time you're screening them for nephrotic proteinuria. So where can you find the amyloid deposit? So you can do a fat biopsy or a fat aspirate, which is what we commonly do. You can also look for it in the bone marrow. Now, if you do fat and bone marrow, about 13% of these patients will still be negative by both those tests in terms of actually being able to demonstrate presence of amyloid deposits. So those are the patients where we actually have to go in and do a organ biopsy. Whichever organ we suspect is being affected by the amyloid, we have to go in and do the organ biopsy. Now, for the longest time, what we have done to demonstrate the protein of origin of the amyloid has been immunohistochemistry. So here's an example of, again, a renal biopsy. On the left-hand side, you can see the apple green birefringence. So we know that there's amyloid. You do immunohistochemistry, and this is all lambda, positive for lambda, negative for kappa. So we know that this is a lambda light chain related amyloid deposit. But the problem that we face is that, and this has been done in multiple studies, that about 10% of patients who present with an amyloid on biopsy will have a coexistent monoclonal gammopathy of undetermined significance. So there's always this concern that you might actually just put those two features together and automatically assume that this is light chain amyloidosis. That's where some of the newer techniques like mass spectrometry really makes a difference. So what happens in the mass spec is that you actually take a biopsy where you can see the amyloid in the perivascular in this particular region. You actually trace those deposits, and you can actually do a laser capture microdissection, which can then be subjected to a tandem mass spec approach. So what it essentially does is when you do the tandem mass spec, you can look at the protein sequence in the amyloid deposits, and you know exactly what protein is leading to the development of the amyloid fibrils. So this test is very specific, and you actually will not make a mistake, and this you can consider this as the gold standard for determining what type of protein is responsible for the amyloid deposits. Now, once you have made the diagnosis, you have demonstrated that there is amyloid in an organ or in the fat pad, and you have done a mass spec and demonstrated that this is light chain amyloid. The next step is to actually look at the disease staging. If you want to get a sense of what organs are involved, because that is the most important determinant of the long-term outcome of these patients. Now, when you look at the spectrum of organ involvement, light chain amyloid can pretty much affect all the organs that you can think of. And the most common organ involved is the heart, as you can see here. The next most common is the kidney, and then there are other organs that can be involved as well. Almost half of these patients will present with a single organ involvement. About a third of the patients actually will have two organs. And about 15% of the patients will have more than two organs involved at the time of diagnosis. Now, as I said, the most common organ to be involved is heart, and the way we can diagnose cardiac involvement, again, multiple approaches. One of the most sensitive ways to look at is an NT-proBNP in the serum. It's a very simple test. If you do an NT-proBNP and that is normal, it's almost impossible that this patient has a cardiac involvement or clinically relevant cardiac involvement with light chain amyloid. Electrocardiogram can show low voltages and some rhythm abnormalities, but they are more likely to happen in the later stages of the disease. Echocardiogram shows increased septal thickness. The strain pattern is something that is again commonly used in this setting and is quite useful for the diagnosis. Diastolic dysfunction is common. MRI scans may show a cardiac nulling, and there are other techniques which can help you identify other type of amyloidosis as well. What about the other organs? Renal involvement typically presents with nephrotic range proteinuria. Renal failure is rather uncommon in the early stages, and you usually denotes very late stage of amyloid involvement. Liver involvement typically is associated with elevated alkaline phosphatase. Hyperbilirubinemia is again a later stage. Patients can present with bilateral symmetrical peripheral neuropathy. Motor neuropathy is again less common. It mostly tends to be sensory. GI involvement predominantly, again, slow gastric emptying, diarrhea, malabsorption are the common symptoms. And patients can have coagulation abnormality, in particular factor 10 deficiency, because it often tends to get absorbed by the amyloid fibrils, especially in the spleen. So what are the different prognostic factors when you think about patients with amyloidosis? As I said in the beginning, the most important prognostic factor is the number of organs involved and the degree to which each individual organ is involved, particularly the cardiac involvement. There are other factors like serum uric acid that has been described as prognostic factors, and these are mostly organ-related prognostic factors. We also know that there are prognostic factors that are related to the plasma cell clone that is making the light chain, and including the serum-free light chain levels and the bone marrow plasma cell percentage. So how do we prognosticate these patients? This is a staging system that we had developed, which basically utilizes the troponin T, the NT-proBNP, again denoting cardiac involvement, and the free light chain, which basically tells you or gives you an assessment of the plasma cell clone. So by using these three factors, we can actually group these patients into 4 groups with very different outcomes. And as you can see, the patients with the highest risk, nearly half of these patients die within 6 months of diagnosis. So extremely high risk group of patients. Now we also know that patients with amyloidosis, just as we have seen in myeloma, there have been substantial improvement in their survival over time. So this is a very recent publication from our group, again showing that the patients diagnosed in the most recent 5 years have a much better 2-year overall survival, 60% compared to 42% for the patients seen about 10-15 years ago. So clearly the different treatments are making a difference for these patients. So then the question, what are the different treatment approaches we can use for patients with light chain amyloidosis? So obviously the first step is the accurate diagnosis and the risk stratification. And once you do that, then there are broadly 2 different approaches to dealing with patients with light chain amyloidosis. One I think is a little bit more advanced than the second one. There are some more recent advances I will talk about which are very important, I think, or will be important in this disease. So again, going back to the pathology, right? So you have the clonal plasma cells, they are making free light chains. These free light chains then get misfolded, they make the oligomers, then they basically, the amyloid deposits happen in the different organs. And we know that these, the amyloid fibrils can have significant toxicity, so to speak, which can lead to organ dysfunction, leading to all the symptomatology we see with this disease. So how can we approach the disease? So one obvious approach would be to get rid of these clonal plasma cells, which is similar to what we do with all clonal plasma cell disorders, including myeloma and other diseases. So that could include the same treatments that we use for myeloma, include alkylators, the modern agents, as well as stem cell transplant. What about the amyloid fibrils themselves? Now, we have all been trying to develop therapies which can actually get rid of the amyloid fibrils from the organs itself, but haven't had much success until recently. The variety of different monoclonal antibodies have been developed, RNA interference approaches, as well as some natural products have been tried in these patients to try and get rid of the fibrils. So let's first talk about how do we know that the treatment is working in these patients, right? So as I said, the first approach is to try and get rid of the plasma cells. So there's no light chain, so the amyloid fibril cannot form. So an obvious way to assess that response is to make sure the light chains are actually going away. So the hematologic response happens very early on, and that can be measured by looking at the monoclonal protein, primarily the light chain by the free light chain assay. However, what we are really hoping to see is that the organs improve their function. And the way to assess the organ response depends upon what organ you are looking at. So if you're thinking about cardiac involvement, the NT-proBNP or the echocardiographic findings can be used to assess organ response. In the liver, again, we can look at the alkaline phosphatase levels. In the GI tract, the fecal fat is often used, and the serum keratin. EMG potentials can be used for the nerve involvement, and the 24-hour urine protein gives you a sense of what happens with the urinary protein excretion. So for the hematologic response, as I said, again, the free light chain is probably the best indicator that you are actually managing to get rid of the clone that is responsible for the amyloid fibrils. So this has been, again, the Italian group have led the development of the hematologic criteria. what we are kind of targeting is again a very good partial response or better in these patients. So very good partial response means a DFLC, or the difference between the involved and the uninvolved free light chain, is less than 40 milligrams per liter or 4 milligrams per deciliter, depending upon which units your laboratory uses. Ideally, we want to get these patients to a complete response, which means the free light chain ratio is normal. So there is no excess abnormal free light chain. So no fuel to actually form that amyloid fibrils. Now, the reason why we target the complete response or the very good partial response is because we have data from multiple studies demonstrating that if you can get to a complete response, these patients do the best. So here's on the left hand side, you can look at the patients who actually get to a complete response, and then there's the very good partial response, and no response. So the patients who get very good partial response and better do much better in terms of overall survival. Now this is looking at patients who have had a hematologic response. Here's patients who are looking at hematologic response at 3 months. Again, doesn't matter where you look at the response, getting a VGPR or better always translates to a better overall survival in these patients. But we know that the hematologic response is only half of the story. We really want the organs to improve. So the organ response is equally important in determining the outcomes of these patients. So here's an example of patients who get a cardiac response. So again, looking at 3 months and 6 months, patients who have a NT-proBNP improvement, so at least a 300 nanogram per liter or a 30% decrease, has a much better outcome compared to people who had an increase in the NT-proBNP while they were getting therapy. So both hematologic response is important, the organ response is important. The hematologic response happens much earlier, so it tells you whether your treatment is on the right track. And once the hematologic response happens, we know that most of these patients you will also see an organ response. So what are the different ways that we can treat patients with light chain amyloid? So the goals of the therapy in these patients, again, we want to get them to a deep response, the VGPR or better. We want them to stay in that response for long periods of time because we know the amyloid fibrils can take a while to actually go away from the organs. But at the same time, these patients are often very frail, especially because of the cardiac involvement. So whatever treatment we use cannot be intense in the majority of these patients. And obviously, because of the multi-organ involvement, supportive care is very, very important. So what are the treatment options we have in terms of trying to get rid of that plasma cell clone? So most of the treatments we use to get rid of the plasma cell clone, you can say, is kind of borrowed from what we have learned to work in myeloma. So we have the high-dose therapy with autologous stem cell transplant. We have Melphalan-based options. More recently, we have the new drugs, the bortezomib-based options and the IMiDs. And we'll talk a little bit more about the fibril-directed therapy, which I think is going to be an important component going forward. So let's talk about stem cell transplant. Now this is a study now almost 14 years ago that Dr. Dispensary did. What she did was basically looked at patients who actually went to a stem cell transplant for amyloidosis. The patients in the middle are patients who could have gone to a transplant but did not go to a transplant. And these are the patients who actually were control population who did not get a stem cell transplant. So we know that when you get a transplant, you do better. But if you are eligible for stem cell transplant, that also puts you in a better shape than the rest of the patients. And when you look at the group of patients that you see in the clinic, only about 20 to 30% of the patients are eligible to go to a stem cell transplant because of a variety of different reasons, primarily cardiac involvement. Now, there's only been one phase 3 trial that has been done. This is looking at transplant versus a non-transplant approaches. And in fact, in that particular study, the transplant arm did worse. But there has been a lot of criticism of the study because, again, transplanting patients with amyloidosis have to be done in centers with lots of experience. And in this phase 3 trial, the early mortality was much higher in the transplant population than what we typically see at centers with a lot of experience. And it's the same when you look at the patients. Again, this is data from the EBMTR, again showing a large group of patients who underwent autologous stem cell transplant. And you can see that the transplant-related mortality, higher than what we see in myeloma, is much less than what we used to see in patients with amyloid 10 years ago, when it used to be as high as 20 to 30%. And we know that it's a very good therapy with a reasonable event-free survival and very good overall survival in these patients. Now, this is the same thing we see. Again, we looked at our own data where we compared patients who go through transplant for amyloid and the patients with myeloma who go through transplant. And again, I think what this highlights is that the plasma cell clone that you see in amyloid is much more amenable to therapy. But the problem is many of these patients cannot get the therapies that we give patients with myeloma because of the significant organ involvement. But when they do get those intense therapy, they do much better than patients who actually have multiple myeloma. And so people have been working trying to see how can we actually build upon that stem cell transplant platform and make it even better. So this is data from Memorial Sloan Kettering where they looked at patients, kind of a dose-adapted therapy for transplant followed by stem cell transplant, followed by consolidation post-stem cell transplant. And again, here you can see that again, this data kind of shows the PFS and the overall survival for these patients, again demonstrating that post-transplant consolidation may be of benefit in some of these patients. So this slide summarizes our current selection criteria for patients undergoing autologous stem cell or patients with amyloidosis whom we are considering for stem cell transplant. So the patients whom we are taking to transplant, they are less than 70 with physiologic age less than 70, reasonably good performance score, a cutoff of troponin of 0.06, creatinine clearance that's more than 30, and NYHA class 1 or 2, and no more than 2 organs involved. And if you use this criteria for selecting patients for autologous stem cell transplant, your transplant-related mortality is less than 5%, compared to when we used to take patients without selection, when it used to be as high as 20 to 25%. So clearly, even though we are limiting the number of patients who can get stem cell transplant, we are giving the therapy only to the patients who can actually tolerate it so they can actually have a good outcome. So what if patients cannot get a stem cell transplant, which is probably about 70 to 75% of the patients with amyloidosis whom you see in the clinic? Those patients, there have been a lot of different trials that have been done, starting even way back in 1997. This is a trial that Dr. Kyle did looking at colchicine in these patients, again in comparison or in combination with Melphalan prednisone. What we know is that when we use Melphalan prednisone type regimens, your hematologic response rate is only about 30%, and your median survival is not more than a couple of years. So clearly not very good therapy for these patients. So there have been other Melphalan based regimens. Again, this has been studied mostly by the Italian groups to start with, and others have been able to replicate similar results. When you use a combination of Melphalan and Dexamethasone in patients who are not eligible to stem cell transplant, you can get a hematologic response in about 2/3 of these patients with a median overall survival which is, especially in the responding patients, that exceeds 5 years. So instead of using the traditional MP type approach, using the Melphalan and Dexamethasone combination given for 4 days every month appears to have a very good efficacy in this patient population. As I said, since then there have been multiple trials that have looked at the combination of Melphalan and Dexamethasone, and you can see that the median overall survival is somewhere in the range of 4 to 5 years. See if I can move faster here. So the next group of drug that is really beneficial in this group of patients is the proteasome inhibitors, and these are multiple trials have been done looking at the combination of bortezomib and dexamethasone or bortezomib with alkylating agents, again with a very high hematologic response rate, including high rate of complete response, again accompanied by good overall survival results. So this is a case control study looking at Melphalan dexamethasone with bortezomib Melphalan dexamethasone, and again you can see that at least in this case control study there was no significant difference. The overall the response rates were much better, and as you can look at the later part of the curves, you can see that they're starting to separate. So this led to a phase 3 trial that looked at MD versus MBD. This actually was presented recently by Palladini. Again, you can see here that the overall response rate, especially the deeper responses, were higher in patients who were getting the bortezomib based combination. And when you look at the best response, again, you see the similar trend with the addition of the bortezomib to Melphalan dexamethasone. Of course, that comes at the cost of slightly higher toxicity, especially the cytopenias, and neurotoxicity is more when you add bortezomib to Melphalan and dexamethasone. So when you look at the survival in these patients, you can see that the overall survival, there's a trend towards better overall survival for the bortezomib combination. But when you look at the time to second line therapy, certainly there appears to be superiority to adding bortezomib to Melphalan and Dexamethasone. Similar to what we have seen with other therapies, you can see that patients who have a hematologic response or organ response do much better than those who don't. So all this is kind of summarized in this kind of represents the Mayo approach to treating patients with AL amyloid. So transplant eligible, especially if they have more than 10% bone marrow plasma cells, then we take them directly to an autologous stem cell transplant with or without an induction therapy. Patients who don't want to go to transplant or cannot go to transplant, we treat them with either a Cybody or bortezomib with Melphalan dexamethasone. If they get a VGPR or better, then we can observe them. If they don't, then we give them additional chemotherapy. And in all these situations, it has to be taken in the context of the organ involvement. Somebody with significant cardiac involvement, maybe we want to try and get them to a complete response and not just stop at the very good partial response. So this is patients who have relapsed of the disease. And you can see here again, we are relying mostly on bortezomib-based therapies, and also in some of these patients who are bortezomib refractory, we can look at IMiD-based therapies. Now, obviously, this is just a one example of a patient who was treated with daratumumab. There is a case report that is, or a series of cases that have been published from Stanford, showing that patients can have a dramatic response with daratumumab-based therapies in patients with light chain amyloid. So there are clinical trials that are ongoing right now looking at this alone and in combination with other drugs. So what about fibril-directed therapy? This is some data from our own center looking at the impact of doxycycline. So these are patients who underwent a stem cell transplant who got doxycycline antibiotic prophylaxis because they were allergic to penicillin. So patients who actually got doxycycline did much better compared to the patients who got penicillin prophylaxis. And this is consistent with animal data showing that doxycycline can inhibit the fibril formation in animal models. So NEOD-001 is a new monoclonal antibody that is currently going through clinical trials. So that targets the amyloid fibrils. So this is data again from some of the clinical trials where you can see that here's a patient who actually had a cardiac involvement, was worsening, and then they started on NEOD. You can see that the NT-proBNP gradually going down. And this has been seen with other two large studies that have been done where you can see that the NT-proBNP change while patients are on therapy with NEOD-001. Similar data is also seen in the renal patient population. You can see the proteinuria has significantly decreased while they are on therapy. Obviously, this has to be proven in phase 3 trials, and there are 2 phase 3 trials that have completed accrual, the VITAL study and the PRONTO study. Hopefully, we will get some results from those trials fairly soon, which will tell us for sure if this drug is working as it should, or we believe it is. So I'll skip through that, but I think it's important for these patients not to focus on just those therapeutic approaches, but also the supportive care, because most of these patients have significant, especially the ones with cardiac involvement, can have cardiac failure that needs to be managed very carefully. Patients with, again, significant edema, it's important to manage the symptoms that are associated with the amyloid itself. So the last few slides, I'll just talk briefly about POEMS syndrome. Again, as most of you are aware, the POEMS syndrome has been described almost 80 years ago now. It stands for peripheral neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. Obviously, it has a variety of other features that go with it. This is the diagnostic criteria we use. So patients have to have polyneuropathy and a monoclonal plasma cell disorder. And then they have to have at least one of these 3 major criteria: Castleman sclerotic bone lesions or elevated vascular endothelial growth factor, and at least 1 minor criteria, which are again as shown here. So here's an example of a patient with POEMS syndrome who has a single osteosclerotic bone lesion. Again, you can see that the sclerotic lesions, which sometimes can be PET avid when you do PET scan in these patients. So what are the different skin manifestations we can see in these patients? A variety of different manifestations have been described, and I won't go through all these details here, but as you can see here, it can take a variety of different symptoms and presentations. When you look at the differential diagnosis, I mean, these patients, again, often we have to think about other more common conditions, especially chronic inflammatory demyelinating polyneuropathy or CIDP in somebody who presents with predominantly peripheral neuropathy. Obviously, light chain amyloidosis can sometimes mimic some of the symptomatology we see in patients with POEMs. And of course, it could all be somebody with a muggers and have a totally unrelated set of symptoms or disease that's going on. Again, some of the skin conditions or skin manifestations can also be mimicked by patients with monoclonal gammopathy and a cryoglobulinemia. And again, rarely you can see patients with myeloma who also has sclerotic bone lesions. So none of those things that we describe are uniquely limited to POEM syndrome. So it's important to make the diagnosis when you see the constellation of different symptoms together, and it's important that we apply the diagnostic criteria accurately. So how do we treat these patients? Those patients who present with a solitary bone lesion, I think is the easiest set of patients to treat. You can just radiate them with a curative dose of radiation, and these patients, the vast majority of them have a really nice response, and these patients, both in terms of symptoms as well as hematologic response. And this is again a group of patients who are treated just with radiation, and you can see that the overall survival is excellent in this group of patients. So what about patients who have either multiple lesions or in whom the radiation alone doesn't work? Again, the same drugs that we have studied in myeloma have been studied in this group of patients as well. And as you can see that a wide spectrum of responses can be seen with alkylating agents, immunomodulatory drugs, as well as proteasome inhibitors. There have not been very many prospective clinical trials that have been done in this disease, again, primarily because of the rarity of the condition and the difficulty in enrolling patients. And again, the supportive care, just as with amyloidosis, can be very important, especially patients who present with neuropathy. They need a significant amount of physical therapy to make sure that we, again, allow these patients to recover at the same time when they're getting their hematological therapy. The endocrinopathies, again, replacing the hormones, very important in these patients. Many of these patients can have significant effusions, so these patients should be managed appropriately with diuretics, paracentesis or thoracentesis as needed. There is some isolated case reports of people using Avastin, which is an anti-VEGF antibody that can give a relief in some of these patients. So again, supportive care is very important. So again, kind of looking back, both amyloidosis and POEM syndrome, you're talking about diseases which are more related to, more qualitatively related to the plasma cell clone rather than quantitative. Myeloma, you have a big plasma cell clone. Both these disorders typically have a very small clone, and it's the nature of the monoclonal protein that is really responsible for the disease manifestations. We know that there is some interesting data emerging in terms of the light chain usage and the gene usage for the light chain in these patients. So we know that it is fundamentally an abnormality with the light chain or with the monoclonal protein itself, which probably happening in the context of a microenvironment that is set up to have the end organ damage. So how do we assess response in these POEMs patients? Again, these patients have been followed very closely. You can follow the monoclonal protein. The VEGF level is a very important marker of response in patients who present with high levels of VEGF. You can see a significant drop as these patients respond to therapy. Patients with bone lesions should be periodically monitored with imaging studies as well. So I'll stop there, and thank you for your attention.
Thank you very much, Professor Kumar, for a wonderful presentation. So we could take into consideration that both amyloidosis and POEMs are sequelae of monoclonal plasma cell disorder with different clinical picture, different prognosis, and probably the worst prognosis is amyloidosis, of course. And this is the reason why probably 20% of patients are eligible for autologous transplantation, like in multiple myeloma, probably about 70 to 80%. Am I right? Something like that proportion.
Right.
Mm-hmm. We have not much time, but perhaps one or two questions, vital questions from the audience, please. Profesor Hołowiecki widzę, że ma pytanie, jak zawsze.
Just a short question. Would you please comment on allogeneic transplantation? Is there a place for this technology here?
I would say no. there are obviously reports of people having used allogeneic stem cell transplant. I think it's going to be really challenging in this population. What we have seen when you look at the comparison to myeloma population, this is a clone that's very easy to control with autologous stem cell transplant. And I think taking these patients, especially the ones with significant GI involvement or cardiac involvement, through an allogeneic stem cell transplant and the potential for GVHD can be quite challenging. So it certainly would not be something I would consider routinely in these patients. Patients who are transplant eligible, I would just go with the autologous stem cell transplant, again expecting a median duration of response of about 6 years. And at the end of 6 years, for half of those patients in whom it recurs, there are a lot of different therapeutic options, especially with the new therapies that are coming along.
Yes.
I have a question regarding monitoring in POEMS syndrome. You told that VEGF is very good. Normally, after autologous transplantation, the VEGF range is normal. How is in your practice when it's relapse? It could be only monitoring by VEGF or more?
So you can. I think it's probably going to be multiple things and you need to monitor, and depends on the patient population. So somebody who presents with multiple bone lesions, I think intermittent imaging, especially with PET-CT, can be useful. I think the VEGF probably gives you an early inkling of something is starting to go wrong again, but you still need additional evidence that there is something in terms of organ involvement or in terms of new lesions. I'm not sure if I would necessarily treat somebody purely on the basis of the VEGF going up.
Professor Jędrzejczak, please.
What about heart transplantation and heart involvement?
Right. So I think that we have done probably about 24 patients with cardiac transplants for light chain amyloid. Most of them tend to be, the patients, the younger patients who come in with predominantly cardiac involvement, not much of other organ involvement. I think it's a very reasonable approach for those patients. The hardest thing is, many of these patients obviously cannot go to a stem cell transplant because of the cardiac involvement. So the majority what we have done, we have actually given a cardiac transplant and then taken them to an autologous stem cell transplant, because now they can actually safely go through an auto transplant.
But a priori, you have to get response in amyloidosis in the whole organism before you transplant, because if the before, other organ will be involved.
Right. So I think increasingly we start doing some of the initial therapies. Now we have the drugs available, with especially the proteasome inhibitors. But we have done in the past, especially patients without a significant marrow clone, we have given them the cardiac transplant because that is life-threatening. So they need something right away, and then you basically, as soon as they recover, you take them to an auto transplant.
Any other question? Yes, Professor Saha.
I want to ask you a question regarding the antifibral therapy with the use of doxycycline. It seems to me quite challenging to administer this kind of therapy to the patient with amyloidosis with heart involvement. So how do you select those patients? And is it treatment used as a monotherapy or in combination?
So if I understood correctly, we're talking about doxycycline, right? So our approach has been to pretty much adding doxycycline to all the therapies that are ongoing. So it's interesting when we looked at our own cohort of patients who went through the transplant, the benefit of doxycycline was only seen in people who got a very good partial response or better. So we know that it probably doesn't add much if you cannot control the underlying clonal process. But if you have a hematologic response, then the doxycycline probably accelerates the fibril removal, or at least slows down the new fibril formation.
Question about NT-proBNP as a marker of active disease. If after chemotherapy all markers of the disease like kappa lambda, immunofixation, everything has completely normalized apart from elevated NT-proBNP, can we expect it will eventually come to normal, or I know it is the factor poor prognostic factor, but right. Can we expect that eventually it will normalize?
The majority of the patients who get a hematologic complete response, you will see a cardiac response. The median time to cardiac response is somewhere in the range of 8 to 10 months. So the response can be very delayed. But we also know that patients with very advanced heart failure, even if you get them to hematologic complete response, sometimes you cannot go on past the point where the heart can significantly improve. But I think getting them to a complete heme response at least reassures you that you have given the best possible scenario for them to improve in the future.
Okay, if there is no any other question, thanks very much.